spinal cord. Yes. Make sure you know how to label that. That's the termination of the spinal cord. Right
Where
there.
exactly? Point. If I put it at the box, is not. I'm gonna be mad. Oh yeah.
Wait, it's not cauda equina.
It's conus medullaris.
It's the
Conus
medullaris.
medullaris.
Yes. Cauda equina are the little nerves coming off the end. You can't see those.
That's what you were asking for, right?
No, I was talking about the terminal end of the spinal cord.
Oh, my bad. What were you saying?
Yes. No, I'm not.
That's
His
what we
weather's got
all
me all
think.
messed up. Okay, so preparing for myelograms. We're gonna, of course, clean our table, and being hygienic and clean around the spinal cord, exceptionally important. Not that it's not important for every other exam, but because we're dealing with a highly infectious area, I would say the spine and the area around the spine is gonna be your second most infectious area behind, what's number one? We talked about it.
The infections, the non.
What's the most infectious area that we deal with? Usually has to do with a tube that we insert. Anywhere around the bladder is the most susceptible to infection. Your subarachnoid space and the spine would be the second most commonly infected area. Good thing to remember. We are going to use footboards and shoulder supports because the table will be tilted in different directions to allow that contrast to coat the subarachnoid space. We will also use an image intensifier as needed to get those plain films that the doctor does ask for. To begin with, we will lock it out of place so it doesn't come in contact with the sterile field, because this will be a sterile procedure. I would put a star by that. This is a sterile procedure because we are dealing with the area around the spinal cord, and once again, it's highly infectious, very susceptible to infections.
Which one is the star?
Huh?
Which one you said put a star or no price?
That this is a sterile procedure. Sterile procedure.
Which we have to scrub in.
Yes. All right, so pre-medication may be needed to deaden that area. As you can imagine, sticking a needle into the subarachnoid space, not going to feel too good. So typically they'll have some pre-medication to help deal with that. The patient should also be very well hydrated. They do need informed consent for this exam. And we are, after our scalp image, we're going to put the patient in a prone position to do that spinal puncture. And do y'all remember what the most two common sites were for those spinal punctures? L3, L4, and L4,
Oh,
L5.
my bad. Oh,
Yes, which one is the most common?
Yeah, L2 and 3 is in the textbook.
They do L4 and L5.
What did I say?
You said L3, L4, and then
I said all the
L5.
above?
So it's, but the textbook says, and
Your textbook's right. I'm wondering what I said.
You said L3, L4.
you said a little lower.
2, 3, 3, 4. I'm sorry. 2, 3, and 3 and 4. Which one's the most common of those two options, though?
3 and 4.
3 and 4.
3 and 4. 3 and 4 is the most common injection site. Absolutely. And what is the importance of using those injection sites? Why do we use that space specifically? We talked about that last time.
Because
You got the fluids, so-
I mean, why do we use that space though? Why don't we like do L1 or
It's in
L12?
It's in the caudal
Because-
aquina, not.
Correct, because we want to be below the termination point of the spinal cord to avoid puncturing the spinal cord. We also talked about an alternative. If we cannot access those sites, there was one other area we can use. Do you remember what that was?
Oh, it's C1 and C1 and C2.
C1 and C2. C1 and C2, correct.
It's the most common site to avoid what? Infection?
It's the most common sites to avoid puncturing the spinal cord. Yes.
Avoid paralysis.
C1 and C2 would be an alternative if we could not access those sites. Because there's a little bit more space near the brainstem that we can safely remove that spinal fluid, that CSF. What is that you're eating?
Tamarindo.
Oh, that's good stuff.
Mexican candy.
Why is it in a cauldron?
It's spooky season.
It's a cantarito.
Yeah, cantarito.
Oh, I've never seen that before.
Is it plastic or actual?
What's it taste like? It's like spicy or? It looks like it would be spicy.
Tamarind is,
Finished it.
it's quite sour.
It's sour?
I can't even give you a taste. No, it's not sour. It's like spicy and sweet. So
Oh,
you
but-
ever had like Mexican candy?
I have.
The
Like with
tamarind
Yeah.
dried fruit is
Yeah,
kind of
it
sour.
tastes like that? Okay, interesting.
Oh, I'm not talking about the candy. I was talking about the fruit
Oh my gosh,
itself.
Okay, so
You get it in
even
a
though
bottle.
this is a sterile procedure,
Sorry.
question?
To confirm, it's L2, L3, L3, L4.
And L3, L4 is the most common
What it was
site.
about.
Okay, so even though we're doing a sterile procedure with spinal punctures, guys, keep in mind this is done in the radiology department. So it's almost like a surgical case done within radiology. We do use sterile technique, local anesthetic. We insert the needle, and once that CSF has been withdrawn, that's sent immediately to the laboratory to do labs to see if they want to proceed with contrast injection, if they're doing a full-on myelogram. So they're going to get those labs before they proceed with that procedure. And why is that? Why would we want to get labs on CSF before we do a myelogram? To check for what?
Creatinine.
Infection. Infection. We want to see if the CSF is cloudy, if it has blood in it, or if it has infectious material in it. Because if we do inject contrast with infected CSF, we're in danger of harming the patient quite severely. We will angle the table and use gravity to allow that contrast to move around the subarachnoid space and coat as much of it as possible, which is what you see right here. Is that subarachnoid space in the L spine. We want to see as much of that filled with contrast as possible, and we can only achieve that by tilting the table up and down, and I'm good. Thank you. Thank you.
It was on there.
And or rolling the patient. Sometimes we'll roll the patient to help coat that contrast as well. So tilting the table up and down and rolling the patient will coat that subarachnoid space.
So which way is the table angled? Is it trigeminal or?
If they do both, they do both to coat the entire subarachnoid space. But they're not going to leave them in that Trendelenburg for very long, because what do you think would happen?
It's gonna go to the head.
It'll go all the way up to the brain, which would be dangerous, yes. Okay, so there we go, guys. If contrast is moving in the cervical area, head is positioned in acute extension to prevent contrast from entering the ventricular system. If contrast were to get all the way into the brain, into the ventricles, it could actually kill your patient and or paralyze them severely. So it's actually a very dangerous exam overall. So they're going to put that head in a very specific position to prevent any of that contrast from accidentally flowing all the way up into the ventricles of the brain. That acute extension specifically will compress what's called the cisterna magna, and that is the only position that will prevent contrast from entering the ventricles. If we cannot achieve that position, we're going to have the patient sit up erect. Let gravity cause that contrast to flow down towards the feet. So cisterna magna is a area in the brain that fluid will kind of pool into before it travels down the spinal cord. So in reverse, we want to close that off so that the contrast does not pool in that cistern. It's called a cistern, and then enter into the ventricles. I'm sorry, Jay, what was your question?
By acute extension, you mean just like this, right?
Yes.
That's right.
Head back like this. It's going to compress the cistern. Cisterna magna. It's obviously very uncomfortable for the patient to hold their head like that, but also it's a safety measure. This. Acute extension. Y'all okay over there? We're having charger difficulties? Oh, what a tragedy. Your phone's about to die. We just can't live without our phones, can we?
We cannot.
How did we survive back then? I just don't know.
Don't beat with us.
We had pagers, right? We were so cool with our pagers. Yeah,
Yeah.
we're all
Pigeons.
technological with our pagers, man. Or the Nokia phones, the big Nokias.
Yes.
I can make calls and defend myself.
Okay, post-procedural monitoring is required. Why is post-procedural monitoring required for myelograms? Same thing we just talked about.
Say it one more time.
Why is post-procedural monitoring required for
So the
myelograms?
dye does not travel back to the
To
brain.
make sure the dye does not travel up towards the brain, correct. So thus, we're going to have the head and shoulders elevated 30 to 45 degrees. They will be on bed rest for several hours. Lots of fluid, and of course they're going to check that puncture site to make sure it's not being infected and or bleeding or bruising. Once again, it is absolutely vital that we have the head and shoulders elevated after this procedure, because if we do not, if someone was to actually lay that patient just flat on their back, it could actually kill the patient. If someone was just being sloppy, not knowing what they're doing, that could be you, by the way. If you finish this exam and you just roll them out in the hallway and put their stretcher head down, you just killed your patient. Yeah.
Have you seen any of like those cases done before? Like that happened to a patient?
I've never seen that happen, but I mean, I've done lots of other rounds.